Hey everybody. So this is going to be a little study session for hematology. We had missed the class due to cancellation. I know there's a really good voiceover, but still there's a lot of content. So this will be a little bit helpful to see where you need to kind of really hone in on and where to find the important stuff here. So the first thing I wanted to go over here is diet, especially talking about iron deficiency anemia. Okay, again, this is kind of our most common anemias, really. I just want to get to that here. Just give me 1 second. So we know that there's an inadequate dietary intake for some reason or another. A lot of times it can happen due to malabsorption. It may occur after certain types of GI surgeries, or even a malabsorption syndrome within our gut. So either by mouth or intake, or there's a malabsorption. So one problem or the other, there's a reason for this iron deficiency anemia. It's our most common nutritional disorder in the world. We see this a lot with young women, women of childbearing years, patients who have maybe poor iron diets. And typically, normally, we lose about 1 milligram of iron daily. It could be in our urine, actually in our sweat, even skin and bile, and minor bleeding. But things that we can do, especially for nursing, what's the underlying problem? How can we fix our iron deficiency anemia, right? What's the underlying problem? Is it a dietary problem or is it more of a malabsorption issue? But if we're talking about more for diet and educating patients on what they may need for a diet, we know that they need very, red lean beef, right? That's a big one. We see a lot of iron in our lean red beef. Sometimes turkey, even pork, chicken, and fish. We see this dark green leafy veggies. We see a lot of iron in our dark green leafy vegetables. So those are our main 2 things there. The red beef, red lean beef. We can also find this in turkey, pork, chicken, and that dark green leafy veggies can also help a lot in iron. Moving on, if we were to talk more about medication, so maybe just the diet alone isn't fixing their symptoms. Maybe they need to have a little bit of help with more medication administration. Iron can be given IM. It can also be given IV. We give a lot of secondary sets, or, what do I want to call it? A secondary set of iron. This iron can also be given by mouth. It can either be liquid, and it's really, if we are giving iron by mouth, we want to make sure to educate patients to take this an hour before meals. And also what helps a lot with iron is we need acidity for iron to be absorbed well. So a lot of times giving this with a vitamin C, really even an orange juice, giving iron with orange juice can really help with the absorption because of that acidic environment. It really helps with binding of iron and absorption into our gut. If we were going to give, sometimes we can give iron liquid. So iron can be a liquid. Iron is staining no matter what. So you're going to notice that iron is very dark, whether you're giving this, if it's going to be IV piggyback, or if we're giving this liquid, it's dark. It's a dark brown and it can stain very easily. So really educating the patient to maybe sip this through a straw. It'll avoid staining their teeth. Also educating the patient on starting on some stool softeners. Iron can really promote constipation. So we want to educate on ways that the patient can avoid being constipated, and also for them not to fear when they do take iron, their stools are going to appear more of like a green-black, and that's going to be normal. Also, GI side effects. Iron can cause heartburn. So making sure the patient sits upright for about 30 minutes after they have their iron intake would be a great educational piece for the patient as well. Next, let's talk about, so packed red blood cell administration. So there was a slide, I think later on, let me just find it. It's farther down the line here. It kind of gives a step-by-step, I think it's slide 47. So it really gives a nice step-by-step transfusion process. And this will be good to know. So really hone in on the transfusion process. We even start with gauge. IV access is so important. Really, even before IV access, we know that we need that type in screen, right? So that type in screen is going to give us the patient's blood type, and it's going to help us match us to the correct blood bag that they need, so they're not having a reaction. So type in screens are really important. They always need a 2-nurse verification when they get a type in screen. A second nurse needs to be at the bedside while that type in screen is being drawn to make sure it's the correct patient. And that second verification nurse needs to put on their name and also their employee ID number, just that they verified that that's correct. But after that's done and after we know their blood type with the type in screen, they need good IV access. And we know this through talking about IV therapy the other day, right? A 22 gauge is appropriate for giving blood, but we know, a larger is better and it's preferred. Even an 18 gauge or even 16 is helpful. We know we need to prime the saline, prime our line with only saline. Blood is only hung with saline, nothing else, not D5W, not D5 half normal, not half normal, normal saline. So we're going to prime that Y tubing. Okay, and there's a lot of pictures on the PowerPoint of that Y tubing, and we're actually going to plug that into our patient so we can start a very slow drip. And knowing that we have that IV access and nothing has infiltrated or we haven't lost the line is super important. I can't tell you how many times I've seen nurses come up with their blood bag and they lose their IV site or they didn't know that it's been lost because they haven't checked it prior to going down to getting their blood. So that's a really important pre-part of hanging your blood, is making sure that you have IV access and hooking up a very small rate with your Y tubing prior to going down to the blood bank. Also, prior to going down to the blood bank, you need to know that you have consent and that it's signed by both the doc and the patient. This also happens too. Nurses have kind of been in a rush, went down to the blood bank, didn't check the consent. There's no consent in the chart. And this can delay the transfusion process and unfortunately can waste a bag of blood. We know that blood is only good for 15 minutes while it's from the blood bank to the floor. So you don't have a lot of time to hang that. So if you need IV access or getting consent, that can really put a delay and even, harm the blood bag. Once we know we have that, so we know we have IV access, we know it's good IV access, nothing has infiltrated, we know that we have consent. Now we can go down to our blood bank, get our patient sticker with us. We do our confirmation at the blood bank, and now we know we have 15 minutes to hang the blood when we get back. We know we have the TAR now at BMC, that's the transfusion administration record, and that's the scanning process. So our blood bag is going to have multiple barcodes on it. It's going to have the unit number, the blood type barcode, expiration date, and a few other verification barcodes on there. Some facilities still do a 2-nurse verification process even with barcode scanning. BMC does not. We need this preset of vitals. So before hanging the blood, we need a preset of vitals. This is one of the 3 vital signs that we need. And then once we have our baseline vital signs, we can now spike our blood bag and hang our blood, initiate the transfusion, and it's really important to stay with that patient for 15 minutes, okay, after the blood has started. This is a great time to educate the patient on any transfusion reactions that may occur, signs and symptoms that they should be watching out for, And transfusion reactions typically happen within the first 15 minutes. So that's why that's really important. After that 15 minutes, we need that second set of vital signs, which is the 15-minute set of vital signs. And we would get those at that time. And then the last time you need vital signs is end. So preset 15-minute and end vital signs are your 3 vital signs that you get during the transfusion. And then, yeah, that's the basis. That's the basis of our transfusion hanging process. So get familiar with all those steps. What else do we have? So we did packed red blood cell admin, signs and symptoms. Okay, so talking about acute blood loss anemia. So this is one of the anemias, and this acute blood loss means that the patient is losing blood, whether it by trauma, hemorrhage, surgery, pregnancy, some sort of a traumatic blood loss has happened. And kind of knowing those signs and symptoms would be very helpful. So what they present with, what happens to their blood pressure? It plummets, right? They're going to be hypotensive. Their heart rate goes high, tachycardic. They're going to appear very fatigued, right? Probably pale. So knowing those signs and symptoms of the hemodynamics especially is really important in acute blood loss anemia. And they really present like they're in hypovolemic shock, right? So think of those hypovolemic shock symptoms. Also knowing a little bit about aplastic anemia. And let me just find that real quickly, go over that. Okay, so we know aplastic anemia, the big deal with aplastic anemia is we have pancytopenia going on. So we have peripheral blood pancytopenia, meaning that all 3 types of our blood cells, meaning red blood cells, white blood cells, and platelets, are all depleted. And that means our bone marrow is not functioning to actively produce the red blood cells, the white blood cells, and the platelets. So there's going to be 3 problems going on here, right? We're going to have anemia because of our decreased red blood cell due to decreased bone marrow production of the red blood cell. Decreased white blood cells, meaning that our patients are at huge probably risk for infection, right? And then also decreased platelets, which also means our patients are at huge risk for bleeding if we don't have enough platelets. So all 3 types of blood cells are depleted within the bone marrow. It's a rare anemia, and about 70% are due to autoimmune activity. And what happens is our T cells are destroying our own bone marrow. Our body is attacking itself, and that's why our 3 types of blood cells are not. Our bone marrow isn't producing enough of them because our body is fighting against its bone marrow. Next is hemolytic transfusion reaction. This is probably our most common transfusion reaction that we have. And let me just get to that in a second. So acute hemolytic reaction. This is due to incompatible blood. The most common reason why we have a hemolytic transfusion reaction is incompatible blood. And signs and symptoms of this reaction is we're going to teach the patient that they may have, back pain. They may develop a fever with or without chills, chest pain and flank pain. They may present as tachycardic and tachypnic. And they'll notice that there's some hemoglobinuria too, so a little bit of blood in the urine. And that's really due to the breakdown and the hemolysis of blood due to the reaction. And so because our red blood cells are becoming hemolyzed, we're going to have an increase of blood in our urine. And what is the first thing we should do if a transfusion reaction occurs? And that's going to be stop that transfusion immediately. And we need to notify our provider immediately as well as the lab. Okay. We need to let the lab know. Like we talked about in the voiceover, there's little types of samples on every blood bag of the blood itself. So that little sample can go back down to the lab, and that could be tested to see why this reaction has occurred. Also, labs will need to be done, and also urine. And of course, we're going to test that urine for hemoglobin. Let's see. An allergic transfusion reaction, signs and symptoms of those. And that's kind of easy because if we think of an allergy, it's very, very similar signs to an allergic reaction for a transfusion. Don't confuse this with an anaphylactic, okay? Don't get confused. So anaphylaxis is more of like hemodynamic compromise and really leading to respiratory distress, whereas a mild allergic reaction occurring, that is just when we would see a lot of like more flushing, itching, hives. Sometimes symptoms can just be treated with Benadryl, and really oddly enough, it can be restarted if the symptoms are mild, and they can be controlled with Benadryl. Some providers will say just keep going with the transfusion. So allergic transfusion reactions typically are less severe. Don't confuse them with anaphylaxis. That's more of a severe reaction. And then preventing circulatory overload, we do have many patients that do exhibit, CHF and other overload features, but sometimes still need blood too at the same time. So it's like that double-edged sword. They need the blood, but they don't need the fluid. So really the best interventions that we can do as nurses, and hopefully the providers will give this order, is to make sure, especially if they're having multiple units of blood or even just one unit of blood, providing them with a diuretic. I use this example of a lot. If a patient is receiving 2 units of blood, typically in between the first and second unit, there'll be, you'll have an administration of some Lasix in between, just to make sure some fluid is getting taken off and they don't go into a respiratory distress or respiratory failure due to circulatory overload. And then we talked maybe briefly about this, especially with IV therapy, but central lines, they're a little bit more sensitive because we know that the central line tip ends in the SVC, or superior vena cava. So especially, anything cold being infused into central lines, especially blood, what is needed is actually a blood warmer. It's so important if you have any patient with a PICC line, central line, to please note that they need a blood warmer for the blood to be given. And that's just going to help prevent any vasospasms to the heart. They're getting this cold blood directly to the heart. So we don't want to, have the patient go through any dysrhythmias, vasospasms that can create something a little bit more harsh for the patient. So warming the blood is especially important for central lines. And that is all. And what would be great is if you can focus on these things. And hopefully this is helpful. And if you have any other questions, please give me an email.